wondered what you call it when two people suffer with arthritis? You call them joint sufferers. And once there were a couple of cows who were smoking weed while playing cards. You could say that the stakes were high. Hello everybody, Dr. Ryan here. I hope you and your folks are well. I encourage you to subscribe to my channel so you don't miss out on any upcoming exciting content. Today we are addressing the topic of rheumatoid arthritis. Here's an outline of our talk as customarily the case, an introduction, followed by etiologies, patient presentation in terms of signs and symptoms, looking at a plausible differential diagnosis, investigations and diagnostic evaluation, followed by treatment and management modalities, prognosis and complications, and then we're going to summarize the key points for takeaway. And of course, we're going to encourage some scripture. Thank you so much, guys, for joining me. I really appreciate your friendship on my channel, and I pray God bless you. Okay, which of the following is the earliest plain radiographic finding of rheumatoid arthritis? Is it A, juxta-articular osteopenia? Is it B, no abnormality? Is it C, soft tissue swelling? D, subchondral erosions? Or E, symmetric joint space loss? Nice question to ask, guys. So rheumatoid arthritis is a chronic inflammatory disease of unknown etiology. Nobody really knows where it comes from or what causes it. It's characterized by synovial proliferation, cartilage destruction, and bony erosion. Frequent flares occur and systemic involvement is common. Appropriate treatment can limit joint destruction, making early diagnosis critical to preserve quality of life. Recently developed biological agents, especially your tumor necrosis factor alpha inhibitors, represent a major therapeutic advance. Okay, let's look at etiology, epidemiology, and risk factors, guys. So the etiology, as we say, is largely unknown. It progresses in 3 stages. So first up, the swelling of the synovial joint lining, which is associated with pain, warmth, and stiffness. And next, there is a rapid growth and division of cells, which leads to thickening of that synovium. And finally, these inflamed cells release enzymes that cause bone and cartilage destruction, loss of joint mobility, and further pain. It affects upwards of 1% of the population, and risk factors include obesity, smoking, and too much of coffee, interestingly enough. So environmental and genetic factors also contribute to disease. The genotype which has been associated with rheumatoid arthritis is the human leukocyte antigen DR4. HLA-DR4 is associated with a higher incidence and more aggressive disease. There's also a higher risk in close family members, most prevalent in Native American populations. Females are affected more than males. The peak onset of age is between the ages of 20 and 50 years old. So if you're looking at the worldwide distribution in terms of incidence of rheumatoid arthritis, we are here in sub-Saharan Africa, and the incidence is some 2.5 to 3.6%, quite significant. If you compare this to the States at an incidence of what, 0.7 to 1.3%, all right, and Jamaica 1.9 to 2.2%. The Nordic countries like Norway 0.4%, in the UK 0.8 to 1.1%, right? South America, Brazil 0.4 to 1.4%, right? So quite a significant burden down here in South Africa, and we know there are certain genotypes associated with certain locations, right, as outlined here. So looking at the pathobiology behind the inflammation and the joint destruction, let's have a close look at this. So a genetic predisposition along with environmental factors, the famous two, may trigger the development of rheumatoid arthritis with subsequent synovial T cell activation. Now CD4 plus T cells, there we have it here, activated by the antigen presenting cells, right, APCs, through interactions between this T cell receptor and the class 2 major histocompatibility complex peptide antigen signal 1 with co-stimulation through the CD28 and CD80-86 pathway, as well as other pathways, which is signal 2. In theory, ligands binding our beloved Toll-like receptors, TLRs, may further stimulate activation of antigen-presenting cells inside the joint. Now, synovial CD4 plus T cells differentiate into T helper 1 and T helper 17 cells, each with their distinctive cytokine profile, as we see here. All right. CD4 plus T helper cells in turn activate your B cells, some of which are destined to differentiate into autoantibody producing plasma cells. Now, immune complexes possibly comprised of rheumatoid factors and anti-cyclic citrullinated peptides, the two things we look for in serology for rheumatoid arthritis. may form inside the joint, activating the complement pathway and amplifying inflammation. T effector cells stimulate synovial macrophages and fibroblasts to secrete pro-inflammatory mediators, among which is our beloved tumor necrosis factor alpha. Now, TNF alpha upregulates adhesion molecules on the endothelial cells, promoting leukocyte influx into the joint. It also stimulates the production of other inflammatory mediators such as interleukin 1, interleukin 6, and granulocyte macrophage colony stimulating factor. Now, TNF alpha has a critically important function in regulating the balance between bone destruction and formation. It upregulates expression of DICOF1, which can then internalize your WNT receptors on osteoblast precursors. WNT is a soluble mediator that promotes osteoblastogenesis and bone formation. Now, in rheumatoid arthritis, bone formation is inhibited through the WNT pathway, presumably due to the action of the elevated levels of DKK1. In addition to inhibiting bony formation, TNF alpha stimulates osteoclastogenesis. However, it is not sufficient by itself to induce the differentiation of osteoclast precursors into activated osteoclasts capable of eroding bone. So osteoclast differentiation requires the presence of macrophage colony stimulating factor and receptor activator of nuclear factor kappa B ligand, which binds to rank on the surface of the pre-OC. Inside the joint, rank L is mainly derived from stromal cells, synovial fibroblasts, and T cells. Osteoprotegrin acts as a decoy receptor for rank L, thereby inhibiting osteoclastogenesis and bone loss. All right, so essentially, this is the entire process depicted here. But remember, central to all the inflammation that's happening is our beloved friend tumor necrosis factor alpha. And that underpins why it is so essential in the management of refractory RA to give TNF alpha inhibitors. Okay, guys, so how do patients with rheumatoid arthritis present? Well, there's early morning stiffness, which lasts for more than an hour. With symmetrical joint pain and swelling, it's relieved by rest, right? Stiffness occurs with inactivity, and that is a hallmark of inflammatory joint pain, right? First, it's worse after immobility, first thing in the morning, but as the day progresses, it gets better. And it's of course associated with raised inflammatory markers. You also have fever and malaise. Typical joint deformities, it loves the small joints of the hands symmetrically, and it involves the PIPs and the DIPs, right? So swan neck deformity speaks to an extended proximal interphalangeal joint with a flexed distal interphalangeal joint. Bottom deformity is the other way around, where you've got a flexed proximal interphalangeal joint and an extended distal interphalangeal joint. You can also get subcutaneous nodules and a whole host of extra-articular manifestations, including keratoconjunctivitis, episcleritis, serositis, vasculitis, and pulmonary nodules. Rheumatoid nodules are basically subcutaneous nodules which occur over bony prominences or around the joints. Right? So here we have a beautiful picture demonstrating metacarpophalangeal joint swelling together with subluxation. So you can have volar subluxation at the metacarpophalangeal joints, and we have joint swelling. All right. You can also see the Z-shaped deformity of the thumb right there. Okay. So there's a couple of things you don't want to miss when you're examining a patient with rheumatoid arthritis. This is taken from Talley and O Connor. So you just want to undertake a general inspection, looking for a Cushingoid appearance, remembering a lot of these patients are on steroid therapy and on the weight, right? Then look at the hands. And in the hand, you're going to find most of the signs: the Z-shaped deformity of the thumb, the volar subluxation, and ulnar deviation at the metacarpophalangeal joints. You're going to find your what we mentioned with the swan neck and the Boccinet deformity. You're going to find tendon friction rubs and so forth, right? The piano key sign on the ulnar styloid. And the arms, you may find entrapment neuropathy on the back of carpal tunnel syndrome and subcutaneous nodules. Involvement of the elbow joint, the shoulder joint, and axillary nodes. In the face, you might find eyes, dry eyes speaking to Sjogren syndrome, red eyes speaking to scleritis, episcleritis. Remember, episcleritis will blanch when you ask the patient to shut the eyes and open it. Scleritis doesn't. That's how clinically you tell the difference between those two. You may have splenomegalia perforans, anemia, so you may have subconjunctival pallor on account of anemia of chronic disease on the back of RA, cataracts from steroid use or chloroquine use. In the fundi, you might have changes of hyperviscosity, so very plethoric fundus. which may predispose to clot formation, etc. In the face, you may have parotids, which once again speaks to Sjogren's. In the mouth, you may have dryness, ulcers, and dental caries. Temporomandibular joint, you may have crepitus. In the neck, remember, you want to examine the C-spine, cervical nodes. In the chest, remember, you could have sinusitis. So in the heart, watch out for pericarditis and valve lesions, manifesting with pericardial friction, rub, and murmurs, respectively. In the lung, you may have effusions, fibrosis, infarction, infection, and nodules. Many ways the lungs can be affected in rheumatoid arthritis, together with this syndrome called Kaplan syndrome, which is rheumatoid nodules in the lung in association with mining and certain industrial exposures. Right, in the abdomen, you may have splenomegaly, speaking to Felty syndrome, right, and inguinal nodes, right. So the triad of rheumatoid arthritis with splenomegaly and neutropenia speaks to Felty syndrome, right, and it predisposes to large granular lymphocytic leukemia. Watch out. Examine the hips, the knees, the lower limbs. You may have ulceration because of vasculitis, calf swelling in the case of ruptured synovial cysts, findings of peripheral neuropathy, mononeuritis multiplex, and core compression. Examine the feet, and you may also in the urine have proteinuria and blood on the back of drugs, vasculitis, or amyloidosis. Do a rectal exam as well. You may find blood there. So this is another way. I like the pictorial representation of the extra-articular manifestations of rheumatoid arthritis. So from head down in the eyes, you can have keratoconjunctivitis sicca, scleritis, episcleritis. We said that the difference between episcleritis and scleritis is that one blanches. So episcleritis blanches when you ask the patient to shut the eyes and open it again. Scleritis doesn't. Neurological, you may have cervical myelopathy. In the mouth, you may have xerostomia, speaking to Sjogren's, and periodontitis. Hematological, you can have anemia of chronic disease, neutropenia if you have Felty syndrome, splenomegaly, large granular lymphocytes, leukemia, and lymphoma. Watch out. The lungs are affected in the way of pleural effusions, pulmonary nodules, which is we call Kaplan syndrome, interstitial lung disease, pulmonary vasculitis, organizing pneumonia. In the heart, you may have pericarditis, ischemic heart disease, myocarditis, cardiomyopathy, arrhythmia, and mitral regurgitation. In the kidneys, rheumatoid arthritis can cause a membranous nephropathy as well as secondary amyloidosis. GI, it can cause vasculitis. Skeletal, it predisposes to osteoporosis, also if you're using steroids in the treatment. Endocrine, it can cause hypoandrogenism. Skin, rheumatoid nodules, purpura, and pyoderma gangrenosum are associated. Okay. Now, this is a beautiful comic from MakeComic.com. Thank you to Mr. Jorge Muniz and company, outlining for us the key differences in rheumatoid arthritis versus osteoarthritis. So, from a conceptual standpoint, osteoarthritis is a degenerative disease, whereas rheumatoid arthritis is an autoimmune disease. In osteoarthritis, we have morning stiffness lasting less than 30 minutes, but significantly longer morning stiffness in rheumatoid arthritis. In rheumatoid arthritis, we have inflamed synovium, right? But in osteoarthritis, there's significant cartilage loss. If you look at just the distribution of joint involvement, right, in osteoarthritis, right, there is involvement of the distal antiphalangeal, but not so much the proximal interphalangeal, right? It involves the carpal metacarpal joints of the thumb, causing squaring of the thumb. We have involvement of the C-spine, the lumbar spine, asymmetrical involvement of the hips and knees, as well as it affects the DIP joints essentially. But in rheumatoid arthritis, the buzzword is symmetrical small joint polyarthritis, loves the DIPs, loves the PIPs, loves the carpal metacarpal joint, loves metacarpal phalangeal joints, loves the elbows and the shoulders and the C-spine, not so much the lumbar spine. Affects the knees, the ankles, and the small joints of the feet symmetrically, right? And of course, so the key thing is osteoarthritis mostly asymmetrical, rheumatoid arthritis mainly symmetrical, right? And of course, we get extra-articular involvement in rheumatoid arthritis, right? All right, what's the plausible differential, guys, for rheumatoid arthritis? So you may have a variety of other arthritis diseases to speak of: parvovirus, rubella arthritis, hepatitis C virus, which is associated with cryoglobal anemic vasculitis, don't forget. Psoriatic arthritis, inflammatory bowel disease, associated arthritis, Eng-spond. Those are the seronegative spondyloarthropathies. Relapsing polychondritis, sarcoidosis, Lyme disease, lupus, polyarticular gout, dermatomyositis, and polymyositis, right? Whipple disease, syphilis, polymyalgia rheumatica, fibromyalgia, Sjogren's, and hemochromatosis. Right, so how do you work up a patient in whom you suspect has rheumatoid arthritis? So with the basic tenets of medicine, as we know, do a thorough history and physical exam. You want to examine those joints and assess the ability of the patient to perform activities of daily living in terms of dressing, eating, ambulating, toileting, and hygiene. Right, those are the basic activities of daily living. So you want to assess their, their functional score. You also want to assess the psychosocial impact of the disease. Now, initial labs include a full blood count with a differential, inflammatory markers in the way of erythrocyte sedimentation rate and a C-reactive protein. Get your uric acid level, check your urinalysis, because remember, we said membranous glomerulonephritis, etc., vasculitis on account of RA. Rheumatoid factor and anticyclic citrullonated peptide are essential to make the diagnosis as one of the diagnostic criteria as per the ACR-EULAR diagnosis, right? And one anti-nuclear factor just to exclude lupus, right? If you got a joint effusion, you want to aspirate that synovial fluid, and it's going to generally reveal above 2,000 white cells per microliter with a preponderance of neutrophils, right? With the absence of crystals. Now, let's look at the ACR-EULAR diagnostic criteria for the diagnosis of rheumatoid arthritis, right? Stratified into 4 different parameters. The first one is joint involvement, the second one is serology, the third one is acute phase reactance, the fourth one is duration of symptoms, right? So, if you got involvement of predominantly one large joint, be it the shoulder, elbow, hip, knee, ankle, you score 0. If you got involvement of 2 to 10 large joints, you score 1. But remember, the buzzword is symmetrical small joint arthritis, right? So if you've got involvement of 1 to 3 small joints, including the metacarpophalangeals, the proximal interphalangeal, the thumb interphalangeal, the metatarsophalangeal, and the wrists, you score 2. Involvement of 4 to 10 small joints, you score 3. Involvement of more than 10 joints with at least 1 small joint, you score 5. Right, and if you've got duration of symptoms being less than 6 weeks, you score 0, but more than 6 weeks, 1. Then in terms of your lab work, in terms of your serology, if you've got a negative rheumatoid factor and a negative anti-citrullonated peptide antibody or anti-CCP, you score 0. If you've got a low positive rheumatoid factor or a low positive anti-CCP, which is below 3 times the upper limit of normal, you score yourself 2. If you've got a high positive rheumatoid factor or a high positive anti-CCP above 3 times the upper limit of normal, you score yourself 3. And in terms of the inflammatory acute phase reactance, if you've got a normal C-reactive protein, normal erythrocyte sedimentation rate, you score 0. But if either of these are abnormal, you score 1. Right? So these criteria are aimed at classification of newly presenting patients who have at least one joint with definite clinical sign of virus, not better explained by another disease. If you've got a composite score of 6 or more in terms of these 4 parameters, that means you've got definite rheumatoid arthritis. Right, so looking at the X-ray of the small joints of the hand demonstrating joint space loss, we can appreciate the joint space loss here, right? And erosions of the carpi and the metacarpophalangeal and proximal interphalangeal joints. We can see some juxta-articular osteopenia, some periarticular swelling, but you got joint space loss. Okay, fantastic. Here is an ultrasound, and you can see the area of the joint, the area of the arrow here showing an effusion within the metacarpophalangeal joint. Ultrasound very sensitive, right? Guys, how are we going to manage rheumatoid arthritis? So the goals of therapy are 4 big ones. 1, to prevent joint destruction, because you don't want permanent disability here, in that way. Number 2, you want to relieve the pain and inflammation, because these patients are significantly pained. Number 3, you want to maintain the range of motion. Number 4, maintain independence. So to this end, we speak to non-pharmacological treatment, which includes rest, hot baths, paraffin wax, physio, occupational therapy, then pharmacologically pain relief with non-steroidals, right? Aggressive early intervention with disease-modifying anti-rheumatic drugs. Those are going to help you, right? DMARDs, used singly or in combination, include our beloved hydroxychloroquine, but the anchor drug is methotrexate. You can also use leflunomide and sulfasalazine, other agents like cyclophosphamide, azathioprine, cyclosporin. Then, of course, if the disease is refractory to those, you can use neurobiological agents, probably prevent bone erosions, including etanercept and infliximab, which are tumor necrosis factor alpha receptor antibodies, and anakinra, which is an interleukin-1 receptor antibody. But remember, you want to rule out infection first. So you check your purified protein derivative to exclude latent TB. You want to exclude hepatitis and HIV and active TB as well before you begin therapy with a TNF inhibitor. Reconstructive surgery in patients who develop destructive arthropathy. Now let's have a look, guys. There are a whole truckload of drugs we can use. Let's firstly speak to these in terms of our headings: the drug, the dosage, the serious toxicities to watch out for, other common side effects, how you're going to evaluate and monitor them, right? So in hydroxychloroquine, the usual dose is 200 to 400 milligrams daily for about 5 days a week. But watch out, because it causes irreversible retinal damage, the so-called bull's-eye retinopathy. It's cardiotoxic, causes blood dyscrasias, right? So cytopenias. Other side effects: nausea, diarrhea, headache, and rash. You want to do a fundoscopic exam or refer to the patients to the eye clinic, right, at least every year, especially for about 40 years of age, and that's that. We're going to do formal visual testing and optical coherence tomography. Sulfasalazine is the other drug we can use. Initially, you give 500 milligrams twice a day. For maintenance, you may go up to 1,000 to 1,500 milligrams twice daily. Watch out because it causes granular cytopenia, hemolytic anemia with favism, with G6PD deficiency. It can also cause nausea, diarrhea, and headache. Your initial evaluation is with your full blood count, LFTs, and your G6PD level. And thereafter, you want to do a full blood count every 2 to 4 weeks for the first 3 months, then every 3 months. Okay, methotrexate is the anchor drug in RA management. So you want to give a dose of 10 to a ceiling of 25 milligrams weekly orally. You want to also co-administer with folic acid 1 milligram per day to reduce toxicities. But serious toxicities are many: hepatotoxicity, myelosuppression, infection, interstitial pneumonitis, and is category X in pregnancy. You've got to rule out pregnancy and counsel the patient about the risk of toxicity and teratogenicity if she falls pregnant, right? Other common side effects is nausea and diarrhea, stomatitis, mouth ulcers, alopecia, and fatigue. Initially, you want to do your full blood count, liver function, viral hepatitis panel, chest X-ray to rule out any pre-existing lung disease, because methotrexate can cause interstitial pneumonitis. Okay, monitoring wise, you do your full blood count, your creatinine, liver function every 2 to 3 months. Leflunomide is the other drug we can use at a dose of 10 to 20 milligrams per day, but it causes hepatotoxicity, myelosuppression, infection, and it's category X in pregnancy. We don't really know how it behaves. It's good for the patient not to be pregnant and advise them not to fall pregnant while on the drug because of teratogenic risk. Other common side effects, alopecia and diarrhea. So up front, straight off the bat, full blood count, liver function, viral hepatitis, and then you're going to monitor every 2 to 3 months with a full blood count, creatinine, and liver function, right? Then we've got the family of your TNF alpha inhibitors, infliximab, certolizumab, pegol, etanercept, adalimumab, golimumab, right? Now, all of them compositely as a family can cause increased risk of bacterial and fungal infections because of immunosuppression, the reactivation of latent TB, hence the value of doing a MAN2 test or a PPD before you start treatment. They increase your lymphoma risk, which is kind of controversial, can cause drug-induced lupus, right, which will give you positive anti-histone antibodies, neurological deficits, all right. Now, important, all of them can cause injection site reaction, infusion reactions, and infliximab can cause a transaminitis, right? You want to do tuberculosis screening before you start any of these, and do your liver function test periodically for infliximab and monitor for injection site reactions on the others, all right? Right, then the other options I just want to mention here, right, we have is rituximab, right? We can also use anakinra, which is interleukin-1 receptor antibody antagonist, abatacept. You can use interleukin-6 inhibitors like tocilizumab, serilimumab. But rituximab is the other one we have available locally in public. So the dose is 1,000 milligrams IV times 2 on day 0 and day 14. You may repeat the course every 24 weeks or more. You want to pre-medicate with methylpred 100 milligrams to decrease your infusion site reaction, okay? Toxicities is that it increases your risk for bacterial viral infections, can cause a local infusion reaction, can cause cytopenias, hep B reactivation. Others, it can cause reaction, fever. So up front, you want to do to rule out hepatitis, do your viral hepatitis panel and full blood count, and then thereafter full blood count at regular intervals, okay? The other class of drugs is, of course, your JAK inhibitors, tofacitinib, and company, alrighty? Okay, guys, so in terms of the provisional definition of remission, how do we define remission in rheumatoid arthritis? As per the ACR-EULAR criteria, is that at any time point, the patient must satisfy all of the following: a tender joint count of less than 1, a swollen joint count of less than 1, a C-reactive protein of less than 1, and a patient global assessment of less than 1 on a 0 to 10 scale, or at any point must have a simplified disease activity index score of below 3.3. Guys, what are the prognosis and complications of rheumatoid arthritis? So in general, there are different patterns of progression. Some patients have a slow onset with multiple remissions or relapses, whereas others have an acute, rapid onset. Half of patients are disabled within 10 years. Reconstructive surgery often significantly improves quality of life and decreases life expectancy by some 3 to 7 years. There's a poor prognosis in those who are white females, rheumatoid factor positive disease, so if you're seropositive, patients with more than 20 joints affected, raised ESR from the start, rheumatoid nodules, and joint X-ray changes. Complications include permanent joint deformity, carpal tunnel syndrome, which is entrapment neuropathy, extensor tendon rupture, vasculitis, pericardial effusion, atlantoaxial subluxation. Guys, coming back to our clinical question that we asked, which of the following is the earliest plain radiographic finding of RA? And the answer is juxta-articular osteopenia. So joint imaging, as you know, is critical for both diagnosis and monitoring of disease status in rheumatoid arthritis. The earliest sign of rheumatoid arthritis is juxta-articular osteopenia, although this may be difficult to appreciate on newer digitized forms. Key points to take away, guys. Rheumatoid arthritis is a chronic systemic autoimmune disease that primarily involves the joints. Right? It causes damage by cytokines, chemokines, and metalloproteinases or metalloproteases. Characteristically affects peripheral joints like the wrist, metacarpophalangeals, are symmetrically inflamed, leading to progressive destruction of articular structures, usually accompanied by systemic symptoms. Diagnosis is based on specific clinical lab and imaging features. We spoke to the rheumatoid factor and the anticyclic citrulline peptide, anti-CCP. Treatment involves drugs, physical measures, sometimes surgery. Disease-modifying antirheumatic drugs help control symptoms, slow disease progression. The anchor drug is methotrexate. Okay, my friends, I hope that you'll just allow me to encourage you from the Bible. The book of Proverbs, chapter 6, verse 16 through 19 tells us there are 6 things the Lord hates, 7 are an abomination to him. First up is pride, a proud look, a lying tongue, hands that shed innocent blood, a heart that devises wicked plans, feet that are swift running to evil, a false witness who speaks lies, and one who sows discord among the brethren. And I pray that, when the Holy Spirit fills us, He will make us acutely sensitive and aware of the things that displease the Lord. And I pray we will be able to stay away from these so that we can keep ourselves pure and holy until the return of Christ. Thank you so much, guys. I hope you enjoyed this video. If you did, I strongly encourage you to subscribe to my channel, to like and share this video. Thank you so much. You can find me on Facebook. Just search for Internal Medicine Algorithms and Mnemonics. I'm also on TikTok and Instagram as well. We're looking forward to a couple of exciting videos coming up. We're talking about lupus. We're talking about an approach to anemia. God bless you. Hope to see you on those ones. Have yourself a fantastic day, and I'll see you soon.